Good morning and welcome to this webinar about lower jaw overdenture. I am Roberto Scrascia.
Good morning, this is Nick from Rain83.
I am a dentistry. I'm talking from Taranto, a city on the sea in the south of Italy.
I'm from Bologna, which is another city in Italy, in the northern part of Italy. And I'm responsible by Rain83 company of the international markets.
Thank you so much for this invitation. Today we talk about lower jaw overdenture. Lower jaw overdenture is a fantastic treatment for elderly people, and I'd like to underline that in this webinar we can see the protocol to realize this kind of prosthetic solution. To talk about overdenture, we need to talk about edentulism. Because edentulism is the problem from we can start to build a rehabilitation. Edentulism is chronic, is irreversible, and edentulism is a real pathology, a real handicap for elderly people. In fact, edentulism in elderly people is one of the most important problems in healthcare. The progressive loss of teeth can be associated with significant functional impairment as well as unfavorable aesthetic and psychological changes in patients. Problem related to edentulism incorporate limitation in diet and reduced ability to eat some food. In this picture, we can see the percentage of edentulism in elderly people. For example, in Italy, the percentage is 90% over 65 years old. At this percentage, we must add a percentage of people with hopeless teeth, and finally, we can say that we have a lot of people that need special treatment in elderly people, and in this way, we can find a solution that is smart, cheap, and in the same time reliability. Reliable, ok, reliable, mi segno questa cosa. What is important to underline for edentulism? For edentulism, is important that with the aging, we have some change in our physical aspect, especially in the lower third of the face, because we can lose our teeth, we can lose our alveolar bone, and at the end we have a loss of vertical dimension, and in this way the soft tissue of the lower third of the face haven't the right support. In every treatment that we can build, we can follow a guideline. This guideline is the full denture, because the setup of the teeth of the full denture is our guideline. Talk about full denture. Full denture is a great kind of treatment because we have teeth, but we have pink material, pink prosthetic resin, and in this way, with the pink prosthetic part, we can support the soft tissue of the face, and we can restore the bone resorption. Full denture were the conventional solution for a lot of years, but with implant and with low profile attachment, now we can have a new gold standard for edentulous mandible, because to implant to low profile attachment, as for example OT Equator by Rain83, are the new gold standard for to treat a lower edentulous mandible. According to this, to my opinion, full denture is a treatment, but full denture is a guideline for every kinds of prosthetic treatment. For example, if we like to build a hybrid prosthetic in our patient, we must to start from the setup of the teeth of the full denture. By Nick.
Of course, Dr. Roberto underlined the importance of the technical side and the importance of when to choose the proper treatment according to the patient situation. What we can see also on our side, more on the personal part, is the human aspect related to the rehabilitation, because we really see an impact on how the life of the person will change after the treatment. And this is the important part of the dentist job, to really having the patient able to eat what he loves and not just what he can. So this makes a very big impact on the rehabilitation, and it underlines the importance of the dentist job.
Thanks, Nick. For example, in upper maxilla, we don't have problem to research stability and retention. For example, we can see in this short video how the upper denture is very strong, but sometimes lower denture needs more retention. This is the clinical case. In the upper maxilla we have a good bone and a good soft tissue, but in lower jaw we have a very thin bony crest. This is the typical clinical case in which overdenture is the best kind of treatment, because two implants and two low profile attachments can really change the quality of life of this patient. This is how in mandible we can see the bone resorption. First of all, we can lose our teeth, then the alveolar bone, until the basal bone. In mandible, the bone resorption is, in the most of cases, vertical. We have a vertical bone resorption, and in this way we have some a lot of solution, and this solution depends from the prosthetical space. For example, if we have a prosthetical space between 10 to 20 millimeters, we can build a crown design. But if we have a prosthetical space from 10 to 12 millimeters, is the prosthetical space of the hybrid prosthetics. But we have a real jolly. This jolly is the full denture and the overdenture, and we can use this kind of prosthetic treatment in every prosthetic space. But overdenture in lower jaw, that is a implant retainer and tissue support overdenture, is a winner prosthetic solution for two reasons. This reason, the first reason is the economic factor, because lower jaw overdenture is a good compromise. But the most important thing is the hygiene factor, because two low profile attachment is a really clean solution, and an elderly patients that don't is able to clean very well, we need to build in this mount, in the mount of these patients, a treatment that is very simple to clean. And in this situation, that is the most common situation, to low profile attachment is the best way.
On our side, as a company that is specialized in the production of dental attachments, we were trying to figure the best solution to support the doctor and the patient, having results that are constant and that will have an impact on the quality of life. And this is the reason why Dr. Scrascia will present his clinical results. And we are very proud that he chose our solutions, which you will see in a few minutes. And as Dr. Scrascia was saying, the name is a low-profile attachment, which you will see. And our goal was to create something that was reliable for the doctor and useful for the patient. So this was the goal, and this was the beginning of our clinical research, which took different years to reach the result that you will see in Dr. Scrascia's presentations.
Now we can see in this graphic how patients, the kind of problems in lower jaw full denture. We can see that patients have pain from function and stability because when we have a very thin bony crest, very resorbed bony crest in mandible, the conventional full denture is unstable, and in this way we need to create more retain for this prosthetic solution, and two implants are the best way, two implants and two attachments to retain the classic full denture. We can see in this picture some articles of the last years about overdenture, and I want to underline this article in the middle. This article talk about the quality of life of patients that had a lower jaw overdenture.
It allowed to keep a high quality life standard over the years without any issue related to the treatment.
Thanks, Nick. The attachment system for dental implant overdenture can be classified into single type and bar type. The single type started from the ball attachment. Nick, do you want to say something about ball attachment?
Yes, a small but important part related to the ball attachment system, which many doctors are familiar with. In this image in particular is the gold treatment, which we call TIN treatment, which allow to increase the hardness of the titanium in order to avoid any possible damage over time. This is an important difference in spherical attachments, which are titanium made and sometimes are not TIN coded, but on our side, on ready-to-treat attachment side, it's very important to add this treatment to preserve the functionality of the titanium during the years. As you can see in this image by Dr. Scrascia, you can see mainly the dimensional difference between the two systems, the spherical attachment on a side and the low profile concept on the other side. Our practice as a company, as a ready-to-treat attachment company, which counts on over 37 years of experience in the dental field as a producer of attachment, is to give both options. We are not forcing any professional to say, doctor, you have to switch from spherical to low profile, because we like to keep both philosophies and both options available for the profession. But at the same time, it's important to see the advantages that a low-profile attachment can offer to the doctor. And in this case, it's undeniable that the dimensions have an impact factor in the treatment. Okay, of course, the dimension and the geometry of the attachment is a very important part to consider. But the other, let's say, the other 50% that we have to consider and we have to be aware of is the functionality of the elastic components, which will be placed on top of the attachments. It can be a spherical or a low-profile attachment. Our philosophy as a ready-to-treat is to work on elasticity, to provide a type of elastic connection which is different from the standard rigid connection of the attachments that were used for some years in the market. So we count, as you can see in this little scheme, our philosophy type is on the right side, and it counts on a wider range of engagement of the elastic components with the attachment. It can be the spherical or the low profile. But our philosophy is to maintain the same geometry of the elastic components, but to give a different functionality, elastic functionality, changing the chemical formulas in order to provide the ultimate standard of elastic retention that the doctor will be able to change and adapt according to the patient need and features.
A limit in clinical practice for low-profile attachment is the disparallelism between the two implants. With the classic steel housing, we can compensate between 0 and 13 degrees of disparallelism. But Rain 83 was very smart to bring this innovation on the market. The innovation is the smart box, because we can use always the OT equator in this way without change the attachment that we can screw on implant, but only change the steel housing. We can compensate until 15 degrees of disparallelism. This is in this slide we can see how smart box is made.
Yes, just as Dr. Roberto was telling, the idea was to put the doctor able to compensate even the most divergent clinical cases. So, as we said, we count on a standard metal housing that allow to compensate the implant divergence between the two implants from 0 to 30. But we also now have this new metal housing called Smart Box system, which has an internal fulcrum that allow a rotation. And with this rotation, we can reach up to 50 degrees of correction between the two implants. So misangulation literally is not an issue anymore in overdenture counting on this system. And I want to underline that this research and development of new solution was possible through the support and the clinical research done by many professionals worldwide, and one of these is Dr. Roberto, of course. So we are always trying to go step by step together with the doctor.
I want to underline a fact that is very important in the quality of life of our daily practice. That this particular is that in classical steel housing and in smart box, the elastic materials is the same. We don't need another kind of elastic material to lock our denture. Okay?
Yes, I agree, and this is very important because the concept behind the research is very simple. Actually, is give more options, but with the same attachment and, if possible, with the same tools and components. This is the idea behind our philosophy.
We have two kinds of overdenture. The classical overdenture is two implant and two attachment, and we can call it tissue support and implant retention overdenture. But we have another kind of overdenture when we have a bar, a structure, and a secondary suprastructure. And this kind of overdenture is called implant support and implant retention overdenture. It's important to make a distinction between the various types of surgical timing. We know that when we put the implant in the bone, we have two roads to follow. Or the two-stage technique, when we put the cover screw in implant and cover hole, and after 2 or 3 months we open a flap and go to the secondary phase of the healing, or to put the healing abutment in the time of the first surgery. This surgery solution is called one stage. When possible, is to prefer the one-stage technique, because one-stage technique is less traumatic for our patients. With the one-stage technique, we have a better management of the cost because it's only one surgery time. One stage is ideal in old patients and is optimal in presence of pathologies. For example, diabetes. In this kind of patients, we have only one surgery time. Now we can see a clinical case about one stage. This patient had two hopeless teeth. We took away this teeth and add this teeth on the lower denture, but patients needed more stability. And in this way, two implant is the first choice. Two implants, one stage surgery. We can see the two healing abutment put on the time of the first surgery. The healing. After the healing time, we need to take the transmucosal route. It's a very important step because after these steps we can order the detachment of the right measure. Nick?
Yes, it's very important also to know that we want to put the doctor in the position to really personalize the prosthetic project, and this is the reason why the osteoquater attachment is available in multiple gingival heights, starting from a minimal of 0.5 up to 7 millimeters. In these images you can see a tool that we use to determine the proper gingival height. We call it cuff height measurer. And a very important point to know is that we are able today to supply the doctor, as Dr. Roberto or any other doctor worldwide, to work with all different implant systems, platforms, connections that are available in the market. So we are really focused in having the osteoquater solutions available for all the different platforms that the doctor requires, because the doctor will choose the proper implant system, the proper implant connection according to his experience and according to the clinical case, and we want to put him or her in the position to have the 100% compatible solution. This is very, very important on our side.
I want to underline that osteoquator must be attached over the mucosa. The surface of the attachment must to be over the level of the mucosa, always. The healing abutment were unscrewed, the implant connection were cleaned, and the newest low-profile direct attachment were screwed onto implants using osteoquator square screwdriver, that is this one, with a torque range that depend from the implant connection. In this clinical case, I remember that 25 Newton. We can see the osteoquator screwed on the implant, the separator disc, and the smart box attachment. This is the occlusal view of the separator disc and the smart box. We just empty the lower denture at the level of the attachment, and it's more important to do the resin vent holes. Go over the resin vent hole. We can put the pink acrylic resin into the denture, put the lower denture in the mount on the patient, first with the fingers, and then the patient held with his mount. We can wait until the pink acrylic resin goes too hard, and then polish the denture. This is the attachment. We can put the matrix, the elastic matrix, in the attachment with this holder, and that's all. The patient now has a very stable, very retained lower denture. I'd like to show to you another clinical case. This is the intraoral view of the arches of these patients. Now we decided to build a full denture in the upper maxilla and overdenture implant retainer tissue support in lower denture in mandible. We can see that always we need to do the CBCT to evaluate the bone resorption. This is a hands-free surgery, but we like to use in hands-free surgery, for example, a parallelized mirror, because implants works well if they are parallel. And we can see the treatment evolution. Mandible, open a flap, put implants, healing abutment, one-stage surgery, the healing, the transmucosal route, put the OT equator on implant, the torque branch, separator disc, and then the steel housing. In this clinical case, smart box. Smart box because smart box is able to compensate until 15 degrees, but smart box is a very self-aligned attachment, and sometimes in elderly people to have a really smart self-aligned attachment is a very advantage.
I would like to ask a question to Dr. Roberto, which I think can be interesting also for other colleagues. You mentioned that there is a strict relation between the average holding people and the related edentulism. And I know that in many countries, the overdenture treatment is considered the economical treatment. And maybe many times is suggested after an all-on-4 Toronto Bridge fixed prosthesis as an alternative. But my question for Dr. Roberto is, do you think that overdenture treatment, especially in the lower jaw, can be really considered the first option in terms of successful, in terms of patient comfort, stability, or is it always going to be considered just as the economical option? Thank you, doctor.
Thank you for the question. I am a member of a large study group. This study group says that lower jaw overdenture is the first choice of treatment in elderly people for two reasons. The first reason is hygiene control, because I think that a patient with 18 years old don't clean very well his all-on-4, and in this way two attachment is very simple to clean. And according to this way, two implants and a classic full denture is a very good compromise for the economic point of view. Okay? But the first things that I'd like to underline is the hygiene control, because too low profile attachment is very simple to clean, and clean work is a work that has a long life without complications. A technical step that I prefer is to build a metal reinforcement of the lower jaw. We can use this plastic product of Rain 83, and our dental technician can build in a simple way the metal reinforcement. We can see the patients at the time 0 and the patients at the end of the treatment. We can use some tools to make a good surgery. We can use a parallelized mirror, but we can use this template. It's a steel template to put implants in the position that we have chosen before to make surgery. We can personalize this steel template on to the shape of the mandible. Hold this template with a pin in the middle line, and then put the implants. This template is called parallel kit. This is the healing after 13 days. Just a moment. Okay. After the healing, we can unscrew the healing abutment, take the transmucosal root, and then order the attachment. I'd like to underline these white tools. Nick, can you talk about a holder, the holder?
Yes, the white holder is actually a very simple idea that we developed to be able to keep the abutment in position. And by keep the abutment in position, I mean be sure that it doesn't fall down while we are taking it from our kit and placing it inside the implant. So sometimes the most simple needs are leading the way to develop some smart tools, and in this case, the white holder simply provide the perfect connection between the abutment and the screwdriver from the moment we take it away from our kit to the moment we screw it inside it.
I love the holder because we can move the OT equator very strong. The equator doesn't fall down in the mount of the patients. After, the steps are the same. Separator disc, the classical steel housing, pink acrylic resin vent holes, it's more important, and then and that is the final work. We can see the RX OPT. I'd like to say something about OT equator. Just a few words about other functions of OT equator. For example, in this clinical case, in the upper maxilla, I have used OT equator not as a single abutment for overdenture, but as multi-unit abutment to build a hybrid prosthetic, because OT equator has a lot of function. One of these is we can use it as multi-unit abutment to build bars or to build fixed prosthetics like hybrid prosthetics. This protocol is called OT bridge. We can see 4 OT equator screwed on the implants in the maxilla, and a fixed hybrid prosthetics screwed on OT equator. This is the protocol of OT bridge. We can see the patients at time 0 and the patients at the end of the treatment. And on the right of this slide, we can see the 2 different prosthetic solutions using only one kind of abutment. In the upper maxilla, we use 4 OT equators to realize fixed prosthetics using the protocol of OT bridge, and in the lower jaw we realize a overdenture, tissue support, implant retention with 2 equators as single attachments. Nick, do you want to say something about the different solutions?
Yes, I'm really glad that Dr. Roberto is showing also this part of his clinical results. because it stresses the importance of our philosophy, which was, as I was telling you, to give more options counting on the same attachment. So we were doing this in overdenture solution, giving different options in terms of misangulation correction in overdenture. And now the research that was possible, once again, I want to thank many different doctors around the world, and Dr. Roberto is a friend, but he's also one of these doctors that supported the research, now leading to this new system that allow to go and provide fixed prosthesis treatments counting on the same OT equator attachment, or we can call it now an abutment. But the philosophy is the same, having the doctor to be able to work on all the different implant systems, because we are able today to personalize, customize the OT equator titanium abutment to be perfectly compatible with all the different implant brands and systems. Dr. Roberto is a big representative and opinion leader for Austin company from Korea, which is a very, of course, well-reputed company. And Reality Tree is working with their connection from Austin and from all the other companies in the world. So once again, I want to stress the importance of the flexibility that this type of treatments can offer, to have the doctor work with all the implant systems in overdenture and today also in fixed prosthesis.
Now talk about the bars. The bars in mandible, we can use bars in mandible, but I'd like to underline what's the space of action of the bars. Bars help us in a typical clinical case when we have a strong bone resorption. And this way, with a strong bone resorption, we have a classical clinical case where the nerves are under the mucosa, and in this way a classical overdenture or a classical denture put a great pressure on these nerves, and the patient feels pain. And in this way, we need to build a prosthetic structure that take away this oppression over the nerves. And the only kind of prosthetic solution in this way is the bar. And always we can use OT equator as multi-unit abutment to build this kind of prosthetic structure. We can see the bar, and also we can use OT equator to screw on the bar to retain the denture. We can see the prosthetic space to clean the bar. It's more simple than an all-on-4, because the patients take away the teeth and at the mirror can clean very well every space around the prosthetic connection on implant. I'd like to show to you another prosthetic solution to rescue old works. For example, I'd like to show this lower overdenture on mini implants. We have 4 implants of very thin diameter, and this kind of implants are one piece, and in this way we have balls in classic titanium, not in TAN titanium that is more stronger than the classic titanium. And this way, over the here, we can see that the classic titanium goes to worn, and we need to restore this this work to give at our patient a good quality of life over the year. We can use this very smart invention by Rainy 83.
Concave spheres.
Concave spheres. We can link this concave sphere over the old and worn attachment, and in this way we can give a new life to our work. We can use a cement, a special cement that link very well metal to metal, and this way we can bring and all the worn attachment to a new life. Do you want to say something about Nick?
Yes, an important aspect on this type of treatment is that if the professional, like Dr. Roberto, knows the type of, this is a mini implant of course, but with a spherical connection on top. If he knows the type of attachment that is on top, if he knows the diameter, for us it's fine. But even in case we face a clinical case with all the damaged attachments and we do not have the information on the brand of the typology of attachments, this system can work perfectly well. So it's a type of solution that allows the dental professional to work on any type of old damaged attachment, restoring it and transforming it into a new one that is functional and compatible to Rainy 83 solutions.
Now go to the conclusion of this webinar. At the end of this webinar, I'd like to show to you our philosophy, because we in our study group we are a switch from the bone drive to prosthetic drive implant placement, and to follow this way, guided surgery help us to put implants, OT equator and steel housing in the best way inside the prosthetic space. Guided surgery needs to bring information. We have a lot of ways to bring information. The classic way is the double scan, and with the double scan we need to have a DICOM data from CBCT of the patient and the DICOM data of the prosthetic plan of the lower denture of the patient, and then match all the information. Now we use another kind of protocol that we can call it dual scan modified protocol, where the prosthetic project not is a DICOM data, but is STL data from scannering with in laboratory or from intraoral scanner. With the modern intraoral scanner, we can obtain a very good STL file in very few seconds. It is very simple to obtain this STL file, and then we can match all the information and we can plan the prosthetic. We can plan the surgery. In this way, from the prosthetic project, we can obtain a surgery template that is prosthetical driven. In this way, thanks to guided surgery, I have the possibility to put implant, to put OT equator and steel housing in the best way, because I don't like to have a lot of a compromise. I'd like to plan everything before to act. We can see a short video about this kind of guided template. This is a guided template from the prosthetic project. The patient can hold this guided template with her mount, and we can put the pin to stabilize the template, and then we put the implant. I'd like to thank Rainy 83 especially for a thing, because in my daily practice I need products that are very smart to use, and and products that I can use in every kind of prosthetic solution. And I'd like to thank Rain ATT because this factory is very near to the needs of our dentistry. Thanks, Nick.
I also want to thank Dr. Roberto and Mr. Dejan for the invitation to this webinar. It was my pleasure, even if I'm not a dentist, to join Dr. Roberto and give some of my experience related to these solutions. And once again, thank you for your time and your attention. And a very big thank to Roberto. And we are really glad to be able to work together.
Thanks. Bye.